Hello to everyone. My name is María-Victoria Mateos. I work as hematologist at the University Hospital of Salamanca in Spain. And this study represents the cohort D of the CARTITUDE-2 clinical study. In this study, in principle, 17 patients were included, and they received Cilta-cel as consolidation after autologous stem cell transplantation. And the first 5 patients who received Cilta-cel, they didn't receive lenalidomide maintenance because this subgroup of patients represented a safety running cohort of patients. Concerning the baseline characteristics of the patients, these 17 patients had a median age of 54 years. Majority of the patients presented a performance status 0 or 1. The median time from diagnosis was less than 1 year, and of note, majority of the patients had been treated with proteasome inhibitors and IMS, but it's true that only 3 out of these 17 patients had been already exposed to anti-CD38 monoclonal antibody. Only 3 patients presented extramedullary disease and high-risk cytogenetic abnormalities. Concerning the efficacy, the administration of Cilta-cel as consolidation after autologous stem cell transplantation resulted in an overall response rate of 94.1%, and indeed, all these patients had achieved indeed complete response or better. Of note also, the median follow-up at the moment of the presentation of this update cohort is of approximately 40 months. Responses to treatment with Cilta-cel were durable, and indeed of the 16 responders, 14 were alive and in complete response or better at last contact, including 1 patient lost to follow-up on day 407. 1 progressed and died of myeloma at 11 months, and 1 patient died because of another different reason. Patients received treatment with lenalidomide as maintenance at a dose of 10 milligrams daily. Upon adequate hematological recovery, and indeed the median time to initiation maintenance with lenalidomide after Cilta-cel infusion was 51 days, and majority of the patients tolerate well lenalidomide. Indeed, the median number of cycles is 24, and of note, the overall relative dose intensity was 93.4%, indicating that the tolerability of lenalidomide as maintenance is optimal. In terms of minimal residual disease negativity rate, overall, 81.3% of the patients achieved minimal residual disease negative, and when we evaluate the MRD negativity rate in patients who achieve at least complete response at different time points, at 1 year, 71.4% of the patients were in MRD negative, and it was 72 at 2 years and 75% at 36 months. And after a median follow-up of approximately 40 months, it's relevant to see how, in terms of PFS and overall survival, over 90% of the patients remain alive and progression-free. In terms of safety profile, no new safety signals were observed with this longer follow-up. It had been previously reported 6 patients that developed related neurotoxicities, 1 patient grade 3 diplopia, 1 patient grade 1 paresthesia, which was ongoing from day 18 to time of withdrawal from study at 5 months post-infusion. But there was not cases of Parkinsonism or Guillain-Barré syndrome. No new second primary malignancies were observed with this longer follow-up, and it had been previously reported only 1 grade 3 myelodysplastic syndrome, and this had been previously reported. In summary, I would say that the potential use of Cilta-cel as a consolidation after autologous stem cell transplantation in patients with less than CR after induction and autologous stem cell transplantation showed that a median of 3.5 years of follow-up, a single Cilta-cel infusion led to deep, durable responses with no new safety signals in a population with historically poor clinical outcomes. All 16 responders achieved stringent complete response out of the 17 treated with Cilta-cel plus minus lenalidomide maintenance, and responses were durable. Only one patient had disease progression. Adverse events were consistent with the known safety profile of Cilta-cel, and no new safety signals have been so far reported. In this earliest myeloma patient population, the benefit to risk ratio of Cilta-cel continues to be favorable, and maybe the only pending thing is to see what it is actually the benefit of lenalidomide maintenance after CAR-T, because this is a single-arm cohort of patients, and the best approach in order to evaluate the role of lenalidomide as maintenance after CAR-T would be to conduct a phase 3 randomized clinical study. Thank you very much for your attention.